Hello everyone and welcome to our webinar on understanding cerebral palsy. My name is Claire Smith and I will be your host. We are joined today by our panellists, Nick Mant, physiotherapist at Flying Start Children's Therapy, Becca Toll, special needs mum to Brielle, Dawn Hamilton, special needs mum to Emmy, and Holly Nam, family engagement coordinator at the Family Fund. During today's webinar, Nick will give you an overview of cerebral palsy, how it is diagnosed and the various types of CP. We will also hear about some of the medical interventions that may be recommended by medics and give you a brief overview of the equipment that your child may require throughout their CP journey. Throughout the webinar, you can type any questions you might have regarding CP and we will try to answer as many as we can at the end. I'm now going to pass you on to Nick, who will talk you through the learning objectives of his section of the webinar. Nick, over to you.
Hi, good evening, everybody. So it's Nick here, and we'll start off by talking about the learning objectives, so exactly what I'm going to be talking about. And as Claire said, it's to define cerebral palsy and how it's diagnosed. So we'll look at the long wordy definition and then look at it in real terms, to discuss the different distributions and classifications of cerebral palsy, so the terminology around that, to look at early interventions and what we aim at in the early parts of physiotherapy treatment, and then the long-term goals of how we look at these children as they reach into their teens. We'll look at some of the common equipment used with cerebral palsy quite briefly, and then we'll discuss some of the medical interventions that you might go through. So what is cerebral palsy? The long definition that if you Google cerebral palsy, Rosenbaum is did a big study back in 2000 and something or other, and this was the long definition that they came up with. The problem is it doesn't really explain it to parents. If you've not got any medical training, a lot of those words are quite confusing, so we simplify it onto the next slide. So it's an umbrella term that is permanent but not unchanging for children. It involves a disorder of movement and or posture of motor function. So all children with cerebral palsy have a difficulty with their motor function. It's due to non-progressive interference, lesion or abnormality in the immature brain. So that damage in the brain occurs either during pregnancy or very shortly after. CP is primarily a movement disorder affecting muscle tone of a child. So we'll talk about what muscle tone is in a bit, but all children with CP will have a movement disorder of some sort. As conditions go, it's one of the more common. It's 1 in 400 live births internationally. Although CP is primarily a movement disorder, you can have single or multiple associated difficulties. So some children will have none of these, some will have all. So these include feeding difficulties, whether that's due to the actual motor control of the mouth, the chewing and swallowing mechanism, or due to poor posture, making it difficult to swallow. They often have learning difficulties because the brain has been damaged as part of the cerebral palsy mechanism. They often have behavioral difficulties and autism. So in the general population, autism occurs at approximately 1% within the general population. Within the cerebral palsy population, it occurs approximately 7%. Children with CP often have visual problems and can have hearing problems as well. They often have sensory processing difficulties, whether this be because of the actual way that the brain processes sensory information, so touch, sight, sound, those sorts of things, or it could be from the lack of opportunity to experience new sensory new senses when they are young and developing, so that when they're older they then struggle to manage them. They often have seizures because, as we say, the brain has been affected. The dental problems that occur are often due to the abnormal muscles within the abnormal tone within muscles in the mouth pulling the teeth in different directions, so they can have actual malalignment of their teeth, and also because they haven't necessarily been chewing and swallowing typically as they're developing, from that 6-month weaning stage onwards. They often have digestive and respiratory issues. These are often later on in life and are down to abnormal postures that the children have adopted. So they might be leaning to the side or with scoliosis that affects their actual digestive tract or respiratory function. So what is CP in real terms? It's that umbrella term, and it affects children in a variety of ways. So you can have really, really mild CP, which isn't picked up in a child until they're, 7 to 10. I've had a child referred to me in the past who was 8, I believe, and he was referred with a stiff ankle and ended up being quite a mild CP. And then to the other end of that spectrum, where there is very severe conditions with lots and lots of associated conditions as well. Although it's described as non-progressive, so the cerebral palsy itself, the damage to the brain, is non-progressive. It's unchanging. However, the effects that has on the muscle presents different challenges at different times in a person's life. So as they're growing, often different challenges crop up. It has a variety of associated difficulties, which must be taken into account at all times by the therapists, by the medics, and by parents. And it really, for the therapists, they really have to take this into account when planning treatment. Due to the breadth of complications that are involved, families have a huge number of professionals involved, which includes all therapies, physio, occupational and speech and language therapy, the medics that are involved, social workers, orthotists, all sorts of different doctors. Hopefully, with that huge number of professionals involved, you will have a paediatrician at the centre of the care. Cool. Moving on to causes, more often than not, the cause of cerebral palsy is not known. There's a lot of there's a lot of things that we can partially attribute it to, but more often than not, the actual cause of CP is not known. But it's often believed that CP was due to low oxygen sustained in baby during a complicated birth. That was the old sort of thought. However, that's more rare. It's more often than not, it is not down to low oxygen or a complicated birth. In fact, what's more considered now is that the complicated birth is down to the child not taking part because they have already sustained that damage in the brain. So during labour, a baby will push off, will kick to try and assist the exiting process, but if they've had that damage to the brain already, then they might not do that, which causes a difficult and prolonged labour. It's not always the case, but that's generally the view now. The widely held belief for causes are periventricular leukomalacia, which is shortened to PVL, abnormal development of the brain, stroke either during or shortly after birth, and damage to the brain immediately after birth. So let's look at those in a little bit more detail. So PVL, or periventricular leukomalacia, is quite common in prematurity, and it can be seen on medical imaging. It's damage to the white matter within the brain, which is all the nerves that fire and communicate across the brain. They're held within the white matter. So if there's damage there, then it will interrupt those signals being sent. The early signs of periventricular leukomalacia can appear on an ultrasound scan as little white dots. Sometimes these will progress to the actual cysts, which is what periventricular leukomalacia is. Sometimes they're not. So what will often happen if those early signs are picked up in the early scans in prematurity, a baby will often be rescanned later on to check whether they've progressed. Not entirely sure why it occurs, but it's often due to infection. The abnormal brain development itself, so as the brain is developing within the womb, it can do this incorrectly, whether it's down to a genetic change, again, infection during pregnancy, or trauma during pregnancy. And this can cause changes such as, so the brain is in two halves, and if that central sort of divide doesn't form, that's a condition which can lead to cerebral palsy, or just other genetic changes. The stroke is another cause, and the stroke can be either due to a bleed within the brain, which is a hemorrhagic stroke, or lack of blood to an area of the brain, which is called an ischemic stroke. So ischemia is cell death. So in prematurity, intraventricular hemorrhage, so the intraventricular bit is where in the brain, and the leukomalacia on the previous slide is basically cysts. Hemorrhage is basically a bleed. So nice long words for what could be quite easily simplified. So intraventricular hemorrhage is down to the very, very delicate blood vessels around the structures in the brain called the ventricles. When a premature baby is born, they're very, very delicate and can bleed, and it's graded between 1 and 4. The grades 3 and 4 are the more serious bleeds, which standard will be followed up by therapists as well as consultants. But saying that, although there's a high risk of these bleeds leading to cerebral palsy, not all of them do. So I have seen children in the past with grade 4 intraventricular hemorrhage who has not developed cerebral palsy. So a lot of these things are risk factors and not definite diagnoses. Other things that can lead to an unborn child's stroke would be problems with the mother's placenta, so the actual the baby not receiving enough nutrients through the placenta. Again, infection. Typically urine infections for parents. I think this is a high risk for stroke. Multiple pregnancy, so twins or triplets have a high risk of having a stroke in birth. Whether this is due to twin-to-twin transfusion or loss of a twin during the pregnancy itself can often cause problems with the surviving twin. And damage to the brain during immediately after birth are those complications, the prolonged labours, the cord wrapped around the neck of the baby that they've struggled to get out, or breech presentation that hasn't progressed well, or back to back that hasn't progressed well. Anything that can cause the baby to have too much stress. If doctors are concerned that a hypoxic event has occurred, so a low oxygen event has occurred, and they think that ischemic changes, so cell death changes, have happened, then they will often send a baby for head cooling. So this is only done if babies are 36 weeks gestation or later, because any earlier than that, then the cooling itself there's a high risk of it causing more damage to the baby, so actual death to the baby. But at 36 weeks, they can survive the temperature changes more, and it's basically putting the baby in a hypothermic state, and so damage to the brain is halted because the body doesn't react by sending all of the normal cells and the normal repairing mechanism, and so then the swelling doesn't occur in the brain, so the damage isn't worsened. The head cooling is what's generally attributed to much improved survival rates for complicated births, and is also what's attributed to less what would have been very complex cerebral palsy in the past being less complex. So maybe a quadriplegic baby in the past with this damage, maybe a baby in the past would have had a quadriplegic cerebral palsy, they go through head cooling and they might now be diplegic, or a baby that would have been hemiplegic with the head cooling now doesn't actually have any cerebral palsy. So it's a huge medical advancement that's helped with babies with this sort of brain damage. Moving on to diagnosis. I hope I'm not talking too quickly, but moving on to diagnosis, it can be quite difficult, and it can happen later. It depends. It can often depend on the area that you're in, on how it's diagnosed, and the consultants that are making the diagnosis. If they're a progressive, forward-thinking consultant, that they will take into account the opinions of their team. If not, then they will wait for just medical imaging, and they will only make a diagnosis through medical imaging, which can be a problem because not all babies with CP will have changes to their brain scan. So if you're relying on medical imaging, then it might not give you a diagnosis. However, diagnosis can be made just by looking at a child's birth history, how they are currently presenting, and then the objective findings of a multidisciplinary team. Generally speaking, physiotherapists are well placed to aid this diagnosis because they are more specialist at feeling muscles and feeling how a tone has changed for these children. Before diagnosis is made, it's important to rule out any other conditions. So often children will be sent to genetics to rule out any genetic causes of their abnormal tone. But what else can we rule out? Basically, we rule out any other diagnosis before offering a diagnosis of cerebral palsy. And more frequently now, diagnosis is made early due to much more collaborative working. So working with multidisciplinary teams. So we can give a report, so a physiotherapist might give a report to a paediatrician who might look at that and think, right, that's cerebral palsy, rather than waiting until the child is 2 years old, where the brain scan will be completed and for a more definitive diagnosis, if indeed there is any changes to the brain scan at all. So moving on to the different types of cerebral palsy, and when a diagnosis is made, it will use the distribution, so where in the body the child is affected, and the classification, so what type of cerebral palsy is actually present. It uses those two terms so that other professionals and using that diagnosis, you can build quite a good picture of how severe a child is. However, it doesn't take into account the associated difficulties as well. those associated difficulties should be detailed in clinic notes and reports from paediatricians, so you can have a diagnosis at the top with additional problems below that. Some consultants don't necessarily do that, but it is very useful for families when seeking support from other bodies like charities, for example. So what tone is, and physios, consultants, all professionals that work with children with cerebral palsy tend to be quite awful at actually explaining what tone is, which is pretty rubbish, because all children with cerebral palsy have altered tone, and we'll mention, oh yeah, this is high tone, this is low tone here, and it's not fair on families who haven't necessarily had that explained. So the proper definition is a state of partial contraction present in a muscle in a passive state. So at rest, how ready it is to fire, and how resistant it is to a passive stretch. So if I was to move your arm quickly, if I was to extend your elbow, so going from a bent to a straight position, how much your bicep will resist that. And that's basically how we test muscle tone. We move it quickly in a stretch. So what you'll often see physios do is taking the foot and quickly moving it back, and that tests the tone of the calf muscle, which is a muscle that will, generally speaking, have increased tone if a child has cerebral palsy. There are certain muscle groups which are more likely to have increased tone. The calf is one of those. It's probably the most frequent one that we would see. All children with CP have abnormal tone. It's part of the diagnosis. So high tone, or spasticity is what it's generally called in medical sort of circles, also called hypertonia, so hyper being high. And low tone is hypotonia. But if a child only has hypotonia, generally speaking, it is not cerebral palsy that is causing this, because there has to be an element of high tone as well. Some children with CP will have very tone, so at times it will be high and low, or they might have low tone in one part of their body compared to high tone elsewhere. Quite commonly, we see low tone in the trunk, so in the body, so the child might struggle to hold themselves up, and high tone in their arms and legs, or legs. So onto the distribution. The common term, I need a drink first. The common terminology over here, at least, is hemiplegia, where it affects one side of the body, the nice image below. Diplegia is just your legs, and quadriplegia, all four limbs. That's sort of the classic terminology, but more modern is coming through, and as Europe work together to try and help classify cerebral palsy and collate data to get us a better picture of how it's affecting populations, the terminology that should be used, but often isn't, is unilateral, which is your hemiplegia, because it obviously affects one side of your body, and your bilateral, which sums up your diplegics and your quadriplegics. The bilateral is often more useful because olden day CP that was diplegic, their arms would barely be affected, but with more progress through medical intervention being improved, now what used to be quadriplegics present more like a diplegic because their arms aren't as affected. However, their arms are still affected, so when doing more complicated tasks, the tone in their arms will go up. So you can't really say they're quadriplegic because they use their arms quite functionally and quite well, but they're not diplegic because it's not just their legs that are affected. So now what we would say is bilateral cerebral palsy with legs affected more than arms. It's a bit more mouthy, but it's more easier to explain to people. So classification is what type of cerebral palsy there is. So that's how the cerebral palsy affects the muscle groups. It's generally given, some consultants and some medics are very good at picking up what type of cerebral palsy, but often it does take time and it takes a lot of handling to try and figure it out. Sometimes it's actually quite complicated or quite difficult to pick up. So physiotherapists, having quite a lot of time with children compared to medics, have time to really have a good feel of the muscles. They're also a bit more used to putting the children in different positions and feeling the muscles. So we're quite well placed to help identify the classification. There are 3 different types. One of those types can be further broken down into 2. And as I said before, hypotonia in isolation is not thought to be cerebral palsy anymore. It's usually down to a syndrome, is quite a common thing. So the best known for that would be Down syndrome. Those children are generally hypotonic, so they're quite bendy and quite floppy. So the most common type of cerebral palsy is spastic cerebral palsy, and that is the more preferred term rather than hypertonic, and it is still a widely used term. It's where the muscle tone in the limbs is persistently raised, so it rarely drops to that low tone floppy state. It's generally held quite high tone when the child is awake. Generally speaking, if a child's asleep, their tone will drop, and that's true for everybody. Another important thing for tone, it's present in everyone. So we all have a certain degree of muscle tone, and that varies between person to person. So I personally am relatively low tone, side of normal. So I will slouch, I will lean against walls. And those are the type of people which are generally low tone. The ones which you see that sit with a bolt upright posture or never seem to relax, they are generally the people with, on the normal scale, are the high side of it. So a person should not be atonic, so without tone. So if you're seeing in clinic notes that they are without tone or things like that, they've got it wrong, because everyone has it. If they have got atonia, then you're very worried. So moving back onto this, the spastic cerebral palsies will, oh no, back up. Yeah, so the movements that you'll see with spastic cerebral palsy are very stereotypical, so they will be quite similar between one child and another. So an arm, you'll see that classic arm picture of a child with cerebral palsy, their arm flexed and the wrist bent and the hand in a sort of bent position. We can generally spot that type of position or that posture and know that a child will be a spastic cerebral palsy. Any sort of excitement will increase that tone. So if a child tries to, if a child comes up against gravity, so does more standing activities, then their tone can increase. Children can present with abnormal tone, and we'll have to wait until they starting to move up against gravity before we know how high it's going to be. It's almost like a waiting game. We know we suspect it's going to be raised, but it's not necessarily until they try standing activities that you'll actually see how high it is or see how severe it is, but those sorts of activities will increase it. Extremes in temperature often increase it, especially extreme cold. Sudden sounds, sudden noises will often increase tone, and music can be used. So if it's calming, relaxing music, that might lower tone. If it's fast-paced music, it might increase it. High tone, children with high tone in their muscles, they are not strong muscles. So we often hear parents saying, oh, they're really strong in their legs. And if that's using tone, then it's not necessarily strength, it's uncontrolled contraction. So if you actually manage to get that child working against resistance, so doing an exercise to, I don't know, push their leg away or stand up, they might really struggle to do that activity because the muscle itself is very weak. And then if they then, what the child might then do is use their tone, so they'll switch on because they'll try and the tone will come up and they'll stand and they'll go, oh, look, they're really strong. And it's really quite hard to explain that it's not strength per se, it's uncontrolled contraction. The medical management that we'll talk about later is generally quite good at managing spastic cerebral palsy because because it is the more common form, so we know the effects of it, and it's also more consistent, so it's always high, so we know that a medication to lower it will help rather than being varied high-low, where the medication will help when their child's tone is high, but it'll make it worse when the child's tone is low. Next, we have dyskinetic cerebral palsy, which literally means abnormal movement, so dyskinesia. It's divided into two further groups, and that's often how the diagnosis is given. So it will be given as either dystonic or athetoid rather than dyskinetic. But again, that depends on your consultant. And in truth, it doesn't really matter if the diagnosis is given as dyskinetic or dystonic or athetoid, because they're all they're treated in very similar ways medically. So dystonic cerebral palsy will present, and children's, so their tone will range from very low to very high, and they will get in these extreme, and it's often quite distressing for people to see the postures that these children will get them in, because they will be, fully extended elbows to the point that the elbow is bending backwards, twisted all the way in or all the way out with the wrist fully extended, and it just looks very uncomfortable. And children get stuck in those positions. If with appropriate handling, you can often, what is described as break that pattern, so we can ease the wrist into a bent position and take that arm out of that stuck pattern, but then the tone underneath that then goes very low, so a child will use that tone and be really, really rigid and stuck and up against gravity and holding their head maybe, and it might be pushed back, but then they're not doing it appropriately, so we try and help them into a more appropriate and a more pleasant, comfortable standing position, but that tone then drops and they flop. And it's really it can be quite hard to treat, it can be quite hard to manage, and it can be quite distressing to see. Generally speaking, children with dystonia will, as they try and do something active, their tone will go up, and then that will force them into those abnormal postures. So it's quite hard for a child, if they're sat, they might be reaching forward for a desired toy, which then that deliberate activity forces their tone, which sends their head backwards. So they want to go forwards and reach for a toy, but their head's then thrown backwards because of their abnormal tone. So it makes life really, really hard for them. So we need to think of ways to either normalize that tone or give them enough support that they're able to reach forward. Initially, when the children are young, or dystonic children are young, they will adopt quite varied postures. So unlike the spastic cerebral palsy, where their arms or their legs will all, generally speaking, go the same way, dystonic children will go in lots of different ways when they're young. They will all be end range, so maximum bent arm or maximum straight arm, but they will vary. As they grow, the variety will reduce, and they will generally head towards one type of posture. And a good example of that is dystonic children that might use their tone or learn to use their tone to help keep the head up by having their arms fully straight, twisted, and sitting on the back of their hands, and then that holds their head up, which is great if they want to look around, but pretty tough if they want to actually use their hand, because as soon as they use their arms, the tone drops and the head falls. So we need to start early on helping them develop their trunk support so that they can actually use their hands and not rely on these postures. Persistent adoption of these postures as well will put joints at risk. So if they're always extending that elbow as hard as they can, then it puts the elbow joint at risk, bending too far backwards. Quite often the trunk tone is quite low in dystonic cerebral palsy, and it's down to damage to the basal ganglia within the brain. So if you do have a scan, they might be able to spot that it's in that particular area, so you've got an increased risk of dystonic or athetoid CP because they're in the same place. So athetoid CP, I'm not sure if we've got the video working on this. It's quite hard to describe these movements, but they're sort of writhing. And children with athetoid CP, it's common choreoathetosis, and chorea is, I think, Greek or Latin for dancing, and it's basically uncontrolled writhing movement that starts in the joint girdles or starts in the trunk, so shoulders and hips, and it's just constant moving, and they'll move their shoulders, and it's like the child's dancing, but not pleasantly. And it will go in the mouth, and it will go in the head, and the body. If it's just one side of the body, then it will just be that one side. But generally speaking, it's quadriplegic cerebral palsy that the athetoids will be, and so it'll be all limbs will be moving. Commonly these movements are present at rest, but they increase when a baby or a child tries to move out of them. So if they're trying to reach forward, their arms will be going in uncontrolled ways, or their jaw and their mouth will be moving left and right. Claire, did we have the video working?
No, Nick, we don't have the video working, but we can put it up on our YouTube channel at a later date and people can refer to it there.
Yeah, it's a lot easier to see this type of movement than describe it, but this is quite a rare form of cerebral palsy. So it used to be more common when jaundice wasn't managed as well. That's because the bilirubin, so the bits that make the skin yellow in jaundice, would go around the body and then settle within the basal ganglia in the brain, and that blocks some of the firing of the nerves. But with the more modern management of simply phototherapy, so putting babies under UV light, that breaks down the bilirubin and stops it from taking place in the from settling down in the brain. So in some countries where they might not pick up the jaundice as quickly, they do have a higher incidence of athetoid CP. Ataxic CP is the next, and that's the least common form of cerebral palsy, and it literally means ataxia is without order, and it's damage to the cerebellum. And I think of the cerebellum like the filing cabinet of the brain, so it helps order our movement. And if we repeat movements, I think of it like it makes a file in the cerebellum, which the brain can refer to without necessarily thinking about. So walking, for example, the way that we walk is stored in the cerebellum. We don't necessarily think about it. We just simply walk. It never goes up to our higher motor function. So in the top part of our brain, it just sits there. Children with ataxic cerebral palsy, have damage within the cerebellum itself, so can't make these files from forming, so stop these files from actually being formed, but also the movement itself is so uncontrolled that they can't ever repeat movement enough to remember it, and it never becomes rote, as it were. The children look clumsy and shaky. They really struggle to balance. When reaching from objects, they will often overshoot. So if you're, this is an old exercise that helps describe ataxia. If you put your index finger of your left hand up, so you point it with your left hand and hold it in front of your nose by about 1.5 feet, 2 foot, then get your index finger of your right hand and you move it from your index finger of your left to your nose, and you move it to and from those. A child with with ataxic cerebral palsy, when they're reaching for that index finger on their left, their arm would weigh from left to right, they would overshoot it, they would miss it, and they'd keep coming backwards. And when going towards their nose, they'd miss their nose, they'd get in their mouth, they'd poke their cheek, that sort of thing. But children with what's commonly seen in ataxic cerebral palsy is that they keep trying over and over. They don't get as frustrated as we would with the failing of the movement. So if they're trying to stand, they'll be really, really wobbly, they'll try and take a step, be really uncontrolled and fall over, and then they'll get back up and try again. And that's quite a nice thing for us to work with. However, it's really hard to watch because the kid just keeps trying and keeps failing. And obviously, like any form of cerebral palsy, it can vary in its severity and be quite mild and hard to notice the reason behind it. So the milder ones will present as a clumsy child, and they might think that they've got developmental coordination delay or something like that, when in fact it's ataxic cerebral palsy. The more serious children with ataxic cerebral palsy are chair-bound and struggle to reach for objects. The treatment for ataxic cerebral palsy, physio-wise, is to give them something to hold on to, something far away, which can help control that movement of one hand so they can reach forever. And so it's all about stabilizing. Ooh. The European classification, so this is a form that's been coming out in Europe, and this is a nice way of simplifying the diagnosis, and it's useful for medics to refer to, but also I think for parents as well, as long as we understand all the terms involved, so especially tone. And that's a nice way, if you're a parent of a child with cerebral palsy, of looking at that and sort of thinking, is which type of cerebral palsy is my child. I quite like that. I use that a lot with my students when explaining about cerebral palsy. However, to make things really complicated, children can present with mixed patterns, so they can have dystonic, spastic cerebral palsy, and that makes diagnosis hard because obviously, how do we refer to it? My preference would be to be a diagnosis of saying mixed dystonic and spastic cerebral palsy. However, often a diagnosis might be given with what is the highest problem. So more often than not, it would be the dystonic side of the cerebral palsy, and it would be dystonic spastic cerebral palsy with dystonic quadriplegic cerebral palsy, and then in the notes underneath it might say has spasticity in certain muscle groups. But if it was me, I'd rather the dystonic spastic cerebral palsy. Whew. So what do we look at? We know that early intervention is one of the main things that helps children with cerebral palsy in long-term outcomes, because we can get those early building blocks in place. So being collaborative with all the professionals that would give help at that certain particular time. So it would be the physiotherapist, the occupational therapist, the speech and language therapist when that time comes, to help develop normal movement patterns or typical movement patterns, and preventing the child from being reliant on their tone to achieve. So for example, a child with dystonic cerebral palsy might learn to roll by throwing the head backwards and just rolling backwards using gravity. That's a destructive posture, because they will then use that in every position and to communicate, and they'll adopt that a destructive posture with their head back, and that would be long term, that would damage the spine. So we avoid those by teaching the child how to roll appropriately. So it's all about developing early normal movement patterns, but also giving parents an insight in how to manage the tone of their child. So if a child is standing with two legs straight and locked backwards, how can we avoid that? Yes, your child's standing, this is excellent. However, they're using their tones. How do we stop that? Well, we make it a little bit asymmetrical. So we might put a child's foot on a step, or we might get them leaning forwards a bit and putting their weight through their hands, so they're not putting, and that we know that that reduces tone. So sort of teaching parents that, yeah, this is great that they're standing. However, they're using their tone a little bit. This is how we can affect tone. So play soft music in the background, that might chill them out, or things like that. And teaching parents about tone and how they can have an effect on it is very useful early on. But also explaining that weekly intervention isn't enough. Often, if I was a parent of a disabled child, I would definitely want as much intervention as possible. But seeing someone once a week isn't enough, because children learn patterns of movement whenever they're playing. That's how they learn. So it's about explaining that when you're playing with a child, this is how you need to play. These are the things that you need to do as part of your daily routine, as part, not necessarily routine, as part of your just handling of your child, because otherwise they will learn the ways that their body's sending them first, because if they're not thinking about it, and every time that they try and reach forward, the head goes back, the head is going to go back. So let's hold it forwards and let them learn to reach forwards properly. Then as we get older, although the long-term goal is obviously to improve quality of life and maximize a child's ability and inclusion, we know that the persistent effect that tone has on the body structures means that their hips and their spine are at risk. In days gone by, you used to get a diagnosis, and during the diagnosis, the consultant might say, children with cerebral palsy dislocate their hips, they get scoliosis, and they would explain to you that your child will get these postural deformities. However, research shows frequently do, in the UK, the new drive is for a thing called CPIPs to be done, which is a way of measuring joint ranges of movements. Or some trusts use just contracture screening, which is what we used to do until CPIPs came along. And also there are other ways of monitoring a body shape, such as the Goldsmith measures, which monitor a child's posture. And if we know that with adequate monitoring, that if something starts to go wrong, then we can look at what we're doing, whether it's enough to maintain this child's posture. Because if a hip starts to dislocate, then what else can you do? Do you need to put in an extra sleep system? Do you need to change the seat that they're in? Do you need to do anything different to prevent that from happening? And if it's done adequately, we know that we can prevent these things. We know that from experience. Locally, we got the rate of dislocated hips down to 0 at one point. So if all children with cerebral palsy dislocate their hips like it used to be thought, then we would have technically had no children with cerebral palsy, and we've got hundreds. So we know that we can prevent that. So that must be highlighted to people and it must be iterated. The way that's done is through 24-hour postural care. So with the various equipment that we give, we look at 24-hour postural care. I'm not going to go on too much about it because that's a webinar in itself talking about postural care. But that's what, if you want to check, ask your therapist if they're doing or adequately doing 24-hour postural care. But a lot of it is done with equipment. So moving on to equipment. So yeah, why do we use it? It's for 24-hour postural care largely, but it's also to ensure that the child's inclusion is maximized, and to ensure that they've got maximum access to their environment, but also to ensure that they can develop typical or normal movement patterns as well. So the Upsy, for example, does steps nicely. The play pack is great, or Leckey activity set, when they're in for the early intervention side, helps us support a child in position so they can develop typical movement patterns. The other common equipment that's used, so often orthotics are given. So this might be specialist footwear, it might be splints, all those sorts of things. In the UK, we don't give helmets for head shape. We will give them for safety reasons. Other things include wheelchairs, postural supports. So that's like your play packs or your early activity sets. So to ensure that a child's, when they move, they do it in typical ways rather than relying on their tonal patterns. Standing frames are essential for a child's hips to develop, because hips start very, very shallow, and the top of the femur isn't connected to the shaft of it through anything but a bit of cartilage, and it's only through weight bearing that the hips develop. So we need to make sure that standing frames are given anywhere between 1 year and 2 years, because that's 1 year and 2 years, because that's generally when a child who is developing typically would start to stand. So that's when we look at giving standing frames. Walking aids, depending on which ones depending when is appropriate to be given your child. Sleep systems are to maintain that child's posture during the long sleeps that they have, but also augmentative and alternative communication, so AAC to help a child communicate, and iPads are becoming more and more popular in that sort of sense where possible. So talking about the medical interventions, generally speaking, they're used to, there are lots of medical interventions to help with epilepsy and all those sorts of things, but I wouldn't have much of a clue about that. So I'm going to talk about the ones that help control abnormal tone. It's a very specialized area of medicine. Locally, we have a spasticity management clinic in, well, it'd be Leeds, but a tertiary centre where children are referred to. There are some which doctors might try first. So the baclofen is the first one I'm talking to. Doctors might try that before referring to a spasticity management clinic. But then when it gets to things like Botox or anything more serious or more high level, then they should definitely refer to those specialist sort of centres which have access to all of the medical intervention available and will be able to compare the positives and negatives of each of them. The ones that help control tones, so we'll start off with baclofen, which can be given, next slide. Hello, Claire, is anyone there? I'll crack on, hopefully people can still hear me. So baclofen is a medication that lowers a child's overall muscle tone. It can be given for dystonic or spastic cerebral palsy, and it can be given orally or through a pump which is stored underneath the skin and provides the baclofen directly into the spinal cord. The oral tablet form, the positives of it is that it's quite simple. Obviously, you just take it as a tablet. The dosage is very easy to work out for doctors on the age and size of the child, and it can be increased and it can be played with to make sure that the child is getting the effect. It basically, the way it works is it affects the way that the nerve will talk to a muscle, and it means that more signals need to be sent to that nerve before the muscle will actually contract, so it lowers the overall tone. The oral form, because it's digested, affects the whole body, which is a bit of a negative in that it can lower a child's head and trunk control if they're struggling with that, opposed to just working on the legs if that's the area of difficulty. I will refer to legs more than arms because I'm a physio. It might also affect eye control, so children with squints, it can make their squint worse, or it can slow the child's ability to track an object, for example. But for children with global hypertonia, it's often very good, and in the low doses, sometimes the children with just diplegic CP can get good outcomes from it, and it doesn't always affect the trunk and head control and eye control. And if it is stopped, if there are those adverse effects, if it's stopped, it wears off. It's got a relatively short half-life, so it wears off, and then the child will go back to normal. So at least it's not a permanent thing. The intrathecal baclofen is obviously more serious because it's administered straight into the spinal cord. It's only used for severe spasticity or dystonia, I believe, and a child will go to a specialist centre where they'll be given a test dose of baclofen, so injected straight into the spinal cord, and then the effects of that will be monitored to see whether they're appropriate for the intrathecal side of it. Then they will get the pump fitted and the dosage will be altered and played with. Generally speaking, baclofen is quite good because tolerance isn't built to it, so you can have it for many, many years without necessarily needing to increase the dosage unless you grow, which children have a tendency to do. But the only one which some tolerance is built to is intrathecal. So sometimes they have to increase the dosage on that because the body actually builds a tolerance to it. Next is our Botox, which is a very strong toxin. It's pretty nasty stuff. It paralyzes the muscle. I can't imagine why anyone would want to inject it in their face, but there we go. And it paralyzes the muscle for a period of time. Generally speaking, after 6 months, the effects of the botulinum toxin will have worn off because the nerves that innervate a muscle, so the nerves that go to the muscle and tell it to switch on, will grow around the ones that have been blocked by the botulinum toxin. And that's essentially what it does. It blocks the end of that nerve. It's very targeted to specific muscle groups. So if we have a child with very high tone in their calves, but not necessarily the rest of their legs, we can go straight to the calf and go, boom, there you go. And that will give us a window of opportunity where we can work on their walking pattern with appropriate orthotic support. Or if they've got tight muscles, we can stretch it during that period because the tone isn't always putting that muscle in that activated state so we can stretch it, and that's really, really quite good. The injections are usually given ultrasound guided, so they'll actually see the muscle that they're injecting in via ultrasound, and it's usually given with Entonox, so gas and air for the anesthesia. Sometimes I'll apply a cream as well to numb the skin. There is a set dose for any particular size child, and only a certain amount will have an effect on a muscle, so that means that they often have to prioritize muscle groups. So if the whole leg's affected, you might prioritize the calf, but then they've still got tone in the hamstrings and the groin muscles and things like that. So often in those cases, the baclofen end might be more appropriate, but or they just prioritize which muscle groups are more not important, but would have more of a positive effect or more of an outcome, better outcome. Next is orthopedic surgery. It should be seen as a last resort. It's not a primary treatment, definitely. Locally, if our children have to go for orthopedic surgery, we view that we have failed, and that is how it should be viewed, in my opinion, because we shouldn't rely on orthopedic surgery. Very, very minor surgery, like we say minor surgery quite flippantly, like a snip to the gastroc or to the calf muscle, fair enough. But the big surgery which can be done, such as on the bones and the soft tissue as well, we don't want our children to go through that, and it is preventable, so we should avoid it. Soft tissue released surgery, it might refer to a single event multi-level surgery, so SEMLS, and that's when lots of different muscle groups are released to try and allow a child to maybe stand up straighter. And then as it gets more serious or older, if a child has a dislocated hip, then they might need the bony surgery as well to try and get that bone back in the joint, and they might actually completely disconnect the bone, twist it, reconnect it so that it's in a better position. Rehab after surgery is a very long process. We've recently done a new policy at our place of work, and it's 2 years of surgery before 2 years of rehab before a child improves their function, really. And it's 6 months? Is it 6 months to a year before a child actually returns to their pre-surgery strength, let alone actually getting stronger? It's that long for the muscles to improve. So it's a long process, but that needs a lot of commitment from families. So it shouldn't be considered if a child is, or if a family are particularly non-compliant. And the final bit of surgery that we're going to talk about is selective dorsal rhizotomy, which a couple of years ago got quite a lot of press over in the UK, and it was a bit misrepresented because people were coming to us thinking it as a cure for their cerebral palsy. There is no cure for cerebral palsy, and selective dorsal rhizotomy is excellent for the specific group of children that it would work with. For all the others, it's not appropriate. So for it to be appropriate is the child's age between 3 and 12. That's in the hope that orthopedic changes or body structure changes haven't taken place that early on, and also because things like walking patterns haven't been established. So a child's walking pattern is quite established by the time they're 7 to 9. So if you're going to do something like a selective dorsal rhizotomy, you want to do it before their walking pattern's firmly established, so that they can then develop a normal walking pattern. The children it works with is spastic diplegics, and that's because the way the surgery is it cuts 50 to 70% of the actual spinal cord roots, so the bits that come out of the spine, out of your vertebrae. It cuts between 50 and 70% of those, so obviously less signals are being sent to the muscles, and it's done down in the lumbar region, so the lower part of the back, so it won't affect the arms. So that's why it has to be the spastic diplegic or unilateral legs affected more than arms kids. The process is now seen as safe. The risks of it are persistent weakness in the legs and incontinence, but it's so well done now that those are quite rare. This is the group in studies have shown that the permanent reduction in limb tone in this drug has a very positive outcome if the SDR is carried out early in that small population that it's suitable for. I've treated 2 kids that have had this. One in particular had very, very positive outcomes, but because she was a bit older, she needed quite a lot of orthopedic surgery, which has delayed her rehab. But saying that, she has done very, very well, and whereas previously would never have walked without any form, would never have walked without a loss of support or with a walking aid is now able to walk without a walking aid very short distances. She still needs that walking aid for any functional walking, but we can walk across a lounge, and that would have been unheard of before. So for the children that it's appropriate for, this is amazing, but it is not for many. It's for a very small part of the cerebral palsy population. And I think that's enough of my rambling.
Wow, thank you so much, Nick. That was an awful lot for you to get through this evening. We've got a few questions coming in for you, so I'm going to take those first and give others who are on the line a chance to ask some as well. So we've got a question in from Catherine, and it's really about here in the UK. She's wondering, is it usually health visitors who would make referrals for preschool children causing concern? She's worried that if this is the case, then there's potentially going to be a lot of children who can be missed.
It depends on where you are. It's a bit of a difficult question. I'll talk for locally for our area. Yes, it can be health visitors that you mentioned. Yes, health visitors. So the health visitors can use I'm going to talk very UK, the Red Book and the 2-year assessment and things like that to try and identify children who are delayed. And yes, they would be one sort of referral. If there are concerns of delay, then children will often go to their GP and they might make the referral to us, and then we could refer on to consultants, or the GPs will frequently refer direct to a consultant who then refers to us. The children, it depends on how accessible your services are, and it varies quite a lot. So our area, we accept referrals from parents. If they're particularly concerned, they can ring up and we can see them. Often we will direct them to a GP to eliminate any other additional problems, but if we think it's quite a classic delay, then we will see them, we will accept that referral. Whereas across the border from where I'm based, the therapy team will only accept referrals from their community paediatricians. So a child has to go through the process of a GP to paediatrician to therapy. So it's quite different depending on where you live. Yes, children can get missed, and it does depend on how good the person is you're seeing, if I'm honest, and it's as simple as that. But there are nice guidelines and things like that which identify certain areas which increase the risk of cerebral palsy. So a child that isn't sitting by the age of 8 months or walking by 18 months should get a referral to someone to be seen, because we know that's a high indicator of problems, whether that be serious or not. But yeah, the health visitors are a common form, and they should identify those problems from their specific assessment, which they carry out at set times.
We've just got a question in. Anna has asked, does she get a copy of the slides? Yes, Anna, once the webinar is complete, everybody who registered will get a complete copy of all of the slides. I know we've really run over our time, but I hope that everybody found that really, really useful. As I said earlier on in the webinar, a copy will be sent to everybody who registered for the webinar, and it will also be available on the therapist section of the Firefly website shortly. If you live outside of the UK and you do require some help or support from charities similar to Family Fund, what you could do is post it into our community forum, and there maybe be some parents there who'll be able to suggest some similar charities that in your area that might be able to provide help and assistance. Again, I just want to thank everyone for joining us and staying with us for today's webinar. It was a long one. We would personally like to extend our thanks to Nick, Becca, Dawn and Holly for their contribution this evening and the day for Dawn. If anyone has any questions, please feel free to email them to us at customer.enquiries@fireflyfriends.com and we'll respond to them as soon as possible. So that just leaves me to say a massive thank you once again, and we hope you will join us for our next webinar. Bye.